A deficiency of omega-3 fatty acids is one of the top 10 leading causes of preventable death in America. And this prompted researchers such as Dr. Mozaffarian to state that modest consumption of fish or fish oil together with smoking cessation and regular moderate exercise should be among the first-line treatments for the prevention of coronary heart disease death and sudden cardiac death. The American Heart Association recommendations for omega-3 intake is that in individuals, men and women who don't have coronary heart disease, to eat a variety of omega-3 rich oily fish at least twice a week, along with plant-based sources of omega-3 alpha-linolenic acid, which includes flaxseed, canola oil, soybean oils, and walnuts. For those with coronary heart disease, it's advised to consume at least a gram of EPA and DHA, preferably, again, from oily fish. For those that can't, EPA and DHA supplements could be considered as well. And for those with elevated triglyceride levels, 2 to 4 grams of EPA and DHA a day under the direction of a physician. Now, this is really a terrific article, a review article in the New England Journal of Medicine a couple of years ago by Dr. Rafael de Catarina, who summarized the use of omega-3 fatty acids in cardiovascular health. And among the mechanisms of action, I mean, we could have an entire morning symposium just on this, but it lowers triglycerides. Omega-3 lower inflammation, they reduce blood pressure, they lower resting heart rate, increase heart rate variability, increase baroreceptor control, reduce the risk of fatal arrhythmias and sudden cardiac death, improve insulin sensitivity, mildly inhibit platelet function, and decrease the risk for thrombosis, improve endothelial function, and very importantly, reduce features of an inflammatory atherosclerotic plaque. Regarding triglyceride lowering with omega-3 fatty acids, this is actually, we could spend a long time on this slide, but essentially omega-3 fatty acids reduce triglyceride production and increase triglyceride catabolism. And this is a busy slide, but essentially what I showed earlier is that when we have adiposopathy and insulin resistance, the liver pumps out triglyceride-rich lipoproteins, VLDL particles, which then leads to the atherogenic triad of small, dense LDL particles, as well as high triglycerides, low HDL. Well, we know that omega-3 fatty acids can reverse all of those things. And certainly it's been utilized for years in order to lower triglycerides. The prescription omega-3s certainly are utilized in patients with severe hypertriglyceridemia of triglyceride levels of 500 or greater. One of the things that I find to be important to understanding is the fact that our particles, including the VLDL particle, not only have ApoB, but they have ApoC, and specifically ApoC2, which is a cofactor for lipoprotein lipase, so that that cofactor is needed for the catabolism of triglycerides to fatty acids, for the fatty acids to enter the cell. On that same lipoprotein, you can also have ApoC3, which inhibits lipoprotein lipase. And that's really one of the exciting things today is research into ApoC3, because we understand that ApoC3 is lowered by omega-3 free fatty acids. And this study that was presented not too long ago looked at loss of function mutations in ApoC3, and they noted that this disrupts ApoC3 function and is associated with a significant 40% reduced risk of coronary heart disease. So by inhibiting ApoC3, and again, ApoC3 is there to inhibit lipoprotein lipase, one of the benefits of triglycerides is to do that and certainly lower cardiovascular disease risk. Now, omega-3 also affects all aspects of metabolic syndrome. All the risk factors of metabolic syndrome can be improved with omega-3 consumption. It improves insulin function, lowers triglycerides, as I said, lowers blood pressure. It raises HDL and increases the large buoyant LDL, reduces small dense LDL. It promotes fat cell function and reduces adiposopathy, and it reduces inflammation, as we know. Now, the use of omega-3, this was a study, again, looking at omega-3 and inflammation, and we know that we get decreased inflammation as a major driver of metabolic syndrome, and dysfunctional adipose tissue contributes to obesity-related chronic inflammation, so that marine omega-3 fatty acids can attenuate adipose tissue inflammation and dysfunction. As far as blood pressure is concerned, we know that this was a meta-analysis done by Meller and colleagues a couple of years ago of the randomized controlled trials looking at omega-3 and blood pressure reduction. And with this study showed that omega-3 can reduce blood pressure to a level commensurate with other lifestyle changes. It was on an average of 4.5 millimeters of mercury. Clinical trials that show that we can use omega-3 fatty acids to reduce risk are first the primary prevention trials. And again, if I went through every trial, we'd be here till 6 o'clock, but I'm going to hit the main trials. The U.S. Physicians Health Study, published in JAMA in 1998, showed that consumption of at least one fish meal per week reduced the risk of sudden cardiac death by 52%. And when you look at the data in this particular trial, you could see the sweet spot was 1 or 2 servings a week. Beyond that, you didn't get a significant reduction beyond that level. So that's why we say at least consume, and ideally, a cold water, oily, omega-3 rich fish at least once or twice a week. We're talking about salmon, we're talking about albacore tuna, trout, herring, mackerel, sardines. These are all rich in omega-3 fatty acids. The Nurses' Health Study, which, as you know, is a very large study, showed that higher consumption of fish or omega-3 supplements was associated with a lower risk of coronary heart disease and CHD death. And then as far as the epidemiological studies, the largest of them all was conducted by Penny Chris Etherton, Bill Harris, and Lawrence Apple. 25 studies involving over 250,000 participants, and it showed an inverse association between fish consumption and morbidity or mortality from coronary heart disease. How about the secondary trials, people who have coronary heart disease? Well, there's 3 landmark trials that I'm going to discuss. The first is the DART trial. And the DART trial showed that men post myocardial infarction, omega-3 either as consumption of fish or fish oil capsules reduced the 20-year all-cause mortality by 29%, mainly driven by a reduction in CHD mortality. The GC Prevention trial was a landmark trial performed in Italy involving over 11,000 Italians post-myocardial infarction, treated with 1 capsule of 850 milligrams of EPA and DHA. And after 1 year, patients taking fish oil had a 21% reduction in total mortality, a 30% reduction in cardiovascular mortality, and this is very interesting. After only 4 months, there was a 45% reduction in sudden cardiac death. The other really landmark trial was the JELIS trial, which was a Japanese trial looking at Japanese men and women with hypercholesterolemia and additional cardiac risk factors, including 20% of this cohort actually had coronary heart disease. And it was randomized between low to moderate dose statin plus 1,800 milligrams of EPA. And with the punchline is that EPA was noted to be a promising treatment for prevention of major coronary events. And you could see in this trial there was a 19% reduction in major coronary events in those randomized to the EPA plus statin versus statin monotherapy. And that's really an amazing trial when you think about it, because in Japan, they already have a high fish intake with high omega-3 levels. So it was really, many people really were skeptical that there would be any benefit, but nearly a 20% reduction in major events in those randomized. But what was really interesting in this trial was those that, in a sub-study of this trial, those with high triglycerides and low HDL, actually had a 53% reduction in major coronary events. And we've seen this in other trials, in fibrate trials and niacin trials, that if you do subgroup analysis and you tease out those individuals with high triglyceride, low HDL, all these triglyceride-lowering agents are very effective in not only lowering triglyceride, but lowering risk. And it's my feeling, as well as feeling of others, that our trials really haven't been conducted properly. If we are going to be using agents that lower triglyceride, let's, my gosh, at least get individuals in the trials that have high triglycerides to begin with. There is a trial, by the way, today, looking at the REDUCE-IT trial of omega-3 in individuals with high triglycerides, so we'll really know the answer to that in a couple of years. This trial was very interesting and presented just recently at the American Heart Association meetings in November. It's called the CHERRY trial, and it was looking at pitavastatin along with EPA to look at coronary plaque regression using intravascular ultrasound. It was a randomized controlled trial, with the conclusion that additional administration of EPA to high-dose pitavastatin significantly reduced coronary plaque volume in those that had the combination of pitavastatin plus EPA compared to EPA alone, suggesting that the combination therapy of EPA and pitavastatin might reduce residual risk in coronary heart disease patients with aggressive lipid-lowering therapy. How about stroke? Is there any data that omega-3 fatty acids reduce stroke risk? Well, this was another landmark trial looking at the Nurses' Health Study that showed that significant inverse relationship between omega-3 intake and the risk of thrombotic stroke, not hemorrhagic, but thrombotic stroke, with a 50% reduction of stroke, thrombotic stroke, if fish was consumed twice a week. And this just highlighted that higher consumption of fish in this study and omega-3 fatty acids in supplement form was associated with a reduced risk of thrombotic infarction, primarily in women who did not take aspirin, and that was a very important trial. In Haynes, also, a large trial showed that men and women who consumed fish more than once a week had a significantly lower stroke incidence than those who never consumed fish. Now, one question that always comes up is, should we measure omega-3 levels? Well, let's analyze the data. This is Siskovic and colleagues who did a study looking at dietary intake of omega-3 and the risk of primary cardiac arrest, and concluded that dietary intake of omega-3 fatty acids from seafood is associated with a significant reduction in primary cardiac arrest. And this was the data, and this is pretty amazing, where if you looked at the highest quartile of omega-3 index, namely 8% or greater, you had a 90% reduction in risk of primary cardiac arrest, sudden cardiac death, than those in the lowest quartile. And just to point out that the typical American omega-3 index is between 4 and 4.5%. Typical Japanese is between 9 and 9.5%. They have a very low incidence of sudden cardiac death compared to Americans. Now, this is another trial, and it looks almost identical. This was a trial from the Harvard School of Public Health with Albert and Ritger and colleagues that showed almost the identical thing in the Physician's Health Study. If you were in the highest quartile, you had a 90% reduction in risk compared to those in the lowest quartile. So one of the simple things that we could do is to make sure that our patients aren't walking around with low omega-3 levels. Ideally have them normalize their levels with dietary intake of omega-3 rich fish, and if not, certainly we have supplements that can get them there. Now, one of the things that also is interesting is Bill Harris did a study looking at omega-3 as a predictor of acute coronary syndrome, and concluded in this trial that low EPA and DH levels are also an independent predictor of increased risk for acute coronary syndrome, and suggested that blood EPA and DHA levels may serve as a new modifiable risk factor for acute coronary syndrome. This was the Heart and Soul study in San Francisco, which actually looked at those individuals that were above the median for omega-3 levels had a 27% decreased risk of death. These were people with stable coronary artery disease. Another piece of information that making sure that our patients, who certainly have risk factors, but also in the primary prevention population have normal omega-3 levels. And finally, we also know that polymorphisms of fatty acid desaturate, especially the delta-5 and delta-6 desaturase enzymes that convert short-chain unsaturated fats to long-chain unsaturated fats. Well, these polymorphisms can block that conversion. So it's more than just asking a patient, are you consuming adequate amount of plant-based omega-3 in fish? You need to measure the levels. So in conclusion, the vast majority of clinical trial evidence supports the use of omega-3 fatty acids to lower cardiovascular disease risk factors and reduce cardiovascular events, and that omega-3 blood levels vary widely due to differences in intake and genetics, and clinical studies have demonstrated the importance of measuring omega-3 blood levels and suggest that low omega-3 levels can serve as a modifiable cardiovascular disease risk factor. Thank you very much.